Let's look at the general side effects of cancer drugs. Keep in mind, rapidly dividing cells are vulnerable to chemotherapy. General adverse effects of these drugs are targeting the fast dividing cells of the patient's body, like bone marrow, skin, gastrointestinal tract, and reproductive organs. Why do patients get general adverse effects? Chemotherapeutic drugs are cytotoxic agents to block abnormal cell growth. If you are not using targeted therapy, most of these drugs are non-selective. That means they cannot distinguish cancer cells from normal cells. Therefore, they will be destructive to normal as well as proliferating cells. Let's look at one by one. The term myelosuppression means bone marrow toxicity. Often it can be life-threatening. Cancer drugs can decrease the cell division in bone marrow, resulting in a reduced erythrocyte, leukocytes, or thrombocyte production. Many drugs decrease erythropoiesis, resulting anemia. Patients feel fatigue, extreme tiredness, pale skin, fast heart rate, or breathing as a result of this. Epoetin alpha or darbepoetin or even blood transfusion may be recommended in these patients. Cancer cells can decrease leukopoiesis, affecting WBC count. Remember, leukocytes, particularly neutrophils, are the first and primary line of defense against infection. Myelosuppression can increase the risk of opportunistic infections. If there is leukopenia, body will be prone to infections. Often we use filgrastim or pegfilgrastim in these patients. Life-threatening spontaneous hemorrhage or bleeding can result from chemotherapy-induced thrombocytopenia, uh, that is, decrease in platelet production. Often we use oprelvecin or L-trombopag in these patients. Dermal toxicity is the damage in the skin when blocking cell division of keratinocytes. Patients can develop dry skin, xeroderma, then hyperpigmentation and rash. When the cell division in the hair follicle stops, hair loss, texture and pigment changes, or all this can occur. Very few drugs can increase hair growth, for example, and even change in color and curliness. Nail growth slows down, often become thin and brittle. GI symptoms are prominent in some patients. Some cancer drugs alter serotonin release in the GI tract and stimulate the chemoreceptor trigger zone in the brain. This induces nausea and vomiting. It also increases salivation and abdominal contractions. A classic example is cisplatin, that is a platinum analog. This is a highly emetogenic agent out of all the chemotherapeutic agents. And meclorethamine, another nitrogen mustard, that is also a highly emetogenic, one of the highly emetogenic drugs in the group. And in some patients, drugs induce painful sores in the mouth called mucositis. Patients often chew ice to minimize blood circulation in mouth during chemotherapy section. This can lower the delivery of cancer drug molecules in buccal mucosa, tongue and lips. Keep in mind, stratified squamous epithelial cells of the mouth and pharynx are rapidly renewable tissue, hence vulnerable to chemotherapy. Damage to simple columnar epithelium in intestinal mucosa results in diarrhea. Often drug-induced damage of enteric nervous system is common, or dopamine or serotonin agonists or even increased acetylcholine release can increased GI motility, and emesis. Atropine or loperamide may be recommended in some patients or some cases. When cancer drugs affect ovary, absence of menstruation can occur, or testis, azoospermia, absence of motile sperm production in semen. Sterility or infertility can be also predictable in some of the patients. Let's look at some of the questions. Highly emetogenic antineoplastic agent, bevacizumab, chlorambucil, cisplatin, vinblastine. Actually, cisplatin is the answer. 90% or above patients get cisplatin-induced emesis or nausea and vomiting. All the other drugs has only less than 10% chances. Which anti-cancer drug has highest risk of mucositis? Tamoxifen, bleomycin, vincristine, or methotrexate? Of course, it is methotrexate. Methotrexate-induced mucositis is very common. Which organ is most prominently suppressed by vinblastine? Bone marrow, skin, oral mucosa, GI tract. Of course, most of the cells can be affected, but severe myelosuppression or bone marrow suppression is common for vinblastine. Which drug causes permanent scalp hair loss? Doxorubicin, docetaxel, tamoxifen, trastuzumab. Actually, docetaxel can cause permanent scalp hair loss. Which drug temporarily shut down ovaries to protect them during chemotherapy? Doxorubicin, leuprolide, vincristine, cyclophosphamide. The answer is leuprolide. That is a gonadotropin releasing hormone agonist. Actually, continuous administration of GnRH agonist can inhibit ovarian follicular growth. This can be effective for ovarian suppression during chemotherapy. Similar drugs like triptorelin can be useful also. A patient developed chemotherapy-induced neutropenia. Which supportive therapy is recommended in this patient? Neutropenia, that means white blood cell count is less, right? So darbepoetin alpha, of course, Epoetin and erythropoiesis is for the the red blood cells, that is RBC. So that's not the answer. L-trombopag, that is actually for platelet count, to increase platelet count. And filgrastim, of course, that is for white blood corpuscles. And pegfilgrastim, that is actually a long half-life. So both the answers are right. Pegfilgrastim and pegfilgrastim can increase neutrophils. Pegfilgrastim has a longer pegylated form of the filgrastim, which has a longer half-life. So once a month regimen is possible for this one. Okay. So hope this helps. All the best.